I'm on, Margaret.
Not yet. I will tell
you. Very warm welcome this evening, this Wednesday, the 28th of September, the last Wednesday of September 2022. My name is Charles Odongtho, your moderator, and this is Behind the Headlines, and I want to welcome you once again to this edition of Behind the Headlines, when we are going to be taking a look at the health sector, its performance, its challenges. We will be looking at the new emerging challenges in the health sector. That's the challenge of epidemics, and right now we are dealing with the Ebola epidemic. We are just still going through the COVID, and we are going to be discussing all that in light or in respect of the 60 years, looking at the 60 years of Uganda's independence since October 1962. Can we make comparisons, and how are those comparisons? Are we doing better? We must be doing better, but what are those challenges that are not making us do our best? To discuss all this, let me start from the extreme left. We have the not honorable Dr. Henry Mwebesa. He is the Director General of Ministry of Health. Doctor, you're most welcome to this show.
Thank you very much. Good evening, viewers.
Next to him is my namesake. He is the gentleman who said, I am going to open the gates of West Nile at one time. But Dr. Honorable Charles Ayume, he is MP for Koboko Municipality, and he is chairman of the Health Committee, a very powerful committee of Parliament. Doctor, you're most welcome to this maiden appearance that you're making to this show.
Thank you, Charles. Good evening, viewers.
Good. Next to him is Dr. Sarah Biachika. Today we have two Sarahs on the show, two ladies. I'm most pleased, but Dr. Sarah Biachika is Commissioner in charge of Planning, Finance and Policy at the Ministry of Health. Doctor, you're most welcome to the show.
Thank you. Good evening, viewers.
Good. Following is Dr. Ombeva Malande. Dr. Ombeva Malande is a lecturer at Makerere University and also director of ICAVI. ICAVI is the East African Center for Vaccines and Immunization. Doctor, you're most welcome.
Good evening, viewers.
Good. Then our two panelists, starting with the Honorable Martin Ojara Mapenduzi. He is MP for Bardege Laibi in Gulu City. He chairs the Local Government Accountability Committee in the House, the 11th Parliament. Wafoyo Bino.
And good evening, viewers.
Good evening. And finally, the last Sarah, who is a lawyer, not a doctor, not yet a honorable. Sarah Birete is our panelist and is Executive Director of the Center for Constitutional Governance. Sarah, you're most welcome back to the show.
Thank you, Charles, and good evening, viewers.
Dr. Sarah, the other doctor.
Oh, yes, the one of books.
Yes.
But even for medicine is for books. But okay, let's start with the man who knows it all in the sector. He feels the pinch, and he knows, he's like the pilot in the health sector, Dr. Henry Mwebesa. We are at this point where we cannot avoid talking about epidemics. We will not avoid talking about Ebola. The president has just been addressing the nation a few minutes ago, and we are going to be touching on some of the facts that came out there and asking more questions about them. Here we ask questions, and but From your perspective, from your cockpit where you sit at the driving seat of the health sector, where are we at? Are we doing well in terms of the epidemics that we are facing now? The president has just said there is no need to panic and that there is no reason to close any place, to restrict any movement that you guys are handling. Is that where we are at? Can we say comfortably that that is the best position we are in?
Thank you very much, Charles. Indeed, the president has just addressed the nation. He has given the nation all the facts about the Ebola. But let me first remind people that much as we have this Ebola, we are not yet done with the COVID.
Yeah.
So COVID is still with us, and we are still emphasizing protecting ourselves against COVID and maintaining our standard operating procedures. Now, in the midst of all that, I will say we hadn't even put it down. Then we get to this Ebola in Mubende. Like the president said, to date we have 24 confirmed cases with 5 deaths. But with some suspected or what we call probable, who could have died before we started, before we picked the incident, about 19. We cannot confirm exactly that they died because of Ebola, but the fact that they died around the same area with the same symptoms, we think they were related. So we are now having 2 epidemics running concurrently. If you realize the history of Uganda, we are in this belt, which is the same belt with the Congo Basin, where normally have most of these viruses, which live very easily and very comfortably because of our nice environment. So these expose us to a number of epidemics. If you realize this is actually our, I think, 7th Ebola outbreak, counting from the first one in Uguru. Through the number of them, the most recent was in Kasese, you recall.
Yeah.
So now this one in Mubende, which is in Mubende, and the sub-county bordering Mubende of Chegegwa, and then in Kasanda. But amidst all this, what I want to bring out that you remember, even when we started the COVID situation, we were still going on with the Ebola of DRC. At that time, we had just had 3 cases of Ebola in Kasese, and we are still responding to the Ebola. But what I want to emphasize is that out of all these epidemics that we have had, Ebola, I've said about 5 to 6 epidemics over years. We had Marburg in Ukweni. It is also another viral hemorrhagic fever. We had another Marburg in Ibanda. I think that was in 2014 or 2012 there. Ibanda, Kabale. And we've been having also sporadic cases of Crimean Congo. It is also a viral hemorrhagic fever, Rift Valley fever. So what that means is actually, as a country, we have developed our capacity to respond to all these epidemics and emergencies. So we have developed the capacity in our lab system. That's why we were able to detect this case very fast. Actually, if they had come much earlier, we would have detected the epidemic much earlier. But what happened is that there was, I think, delay in the community. They went to local clinics where immediately it was not so typical, and they were managing as a normal fever. So by the time they came to Mubende Regional Referral Hospital, I think the patient who came to Mubende Regional Referral Hospital, the physician said, look, hold on. This case could be something bigger than we thought. So immediately they took off blood, brought it to Virus Research Institute, and tested and confirmed it was Ebola. And immediately we went into gear to respond to the epidemic. Now, that is a capacity that we have built over years. Prior to that, we would have picked that sample and sent it to Atlanta in USA, and would get results in about 2 weeks. And you can imagine what would be happening in those 2 weeks. People would be cautious, but they would also be a bit relaxed. But until the thing is confirmed, then there's usually that tendency, could be, could not be. So we have developed capacity of our lab system that we can detect and produce results within 24 hours and then immediately respond. Actually now, I think you heard the president say, we have even developed mobile labs that we are going to take. I think they have already moved to Mubende. That you take a sample there, bring in the lab, which is a mobile lab, and get results within, say, 3 hours. So we have developed that capacity. We have developed the capacity to send teams down to do contact tracing. Like now we have over 450 contacts of these cases that have been confirmed. So you have teams that can go down, talk to the communities, and then they get information, and then they can be able to follow up the cases, isolate them, and follow them up, and test them. And those who turn positive, bring them to the treatment unit. And those who are negative, they release them to go. We have also developed the capacity for treatment, because the people now treating these people in Mubende are actually not expatriates. They are our people who treated Ebola in Gulu, the people who treated Ebola in Kibali, the people who treated Ebola in Bunduji. So, I can say with confidence that we have developed a resilient system to respond to this situation. I'm not panicking, I'm not scared, but of course at the beginning you lose some people, including our own staff. Sometimes you can lose staff, because the first health workers who see these patients think they are dealing with a normal fever, and most likely get exposed and sometimes get sick. So I can say that we are up to the task. We shall handle this problem. But of course we also have our development partners who support us in many ways, including supporting like the laboratory system I'm talking about. We were able to build those with government support, but also with support from our friends, the US government. Good. So we have the system to handle this.
In terms of this, this contact tracing, how big a geographical scope is it covering in Uganda? Are you only narrowing it for now to Mubende and the neighboring districts of Chegegwa and then Mitiana, or are you doing it nationally?
You know, when we send our teams down, we get the leads. We have epidemiologists, we have social workers, we have people who have been monitoring these epidemics over years, including the same contact tracing that we did for COVID when it was still young. But you remember when the COVID became massive, the contact tracing couldn't work. I mean, if you are getting 1,000 cases per day, what contact tracing would you do? But like in Ebola, like I've told you, the confirmed cases are 19. And we've already been the place, and we have almost 450 people who we are following up. Now we have categorized the spread or the epidemic into 3, the very, very high risk districts, Kasanda, Mubende, and that sub-count of Chegegwa, but of course now for Chegegwa we're covering everybody. Then the districts, I think they're about 20 now, neighboring these 3, all those surrounding. We have also put their feelers. Now, these contacts you get, you have to follow them up where they have gone. If they have gone, let's say, to Chenjojo, then you have to follow them in Chenjojo. You have to send a team to follow those cases in Chenjojo. Because the people in the village, the strength with our system is that we also work very closely with the community leaders, the LOCs, the village health teams, and they know the people. Because even those 19 we are telling you about were reported by the community, the village. They said, in that family somebody died, they had similar symptoms, but we don't know whether it was the disease or not, but they died suddenly, within the same period. So certainly, it rings a bell. They had the same symptoms within the same area, what we are calling the epicenter. So most likely, that's why we call them probable they could be. So then their families, you must have to follow them up. The people who visited them, you have to follow them up. The health centers where they went, actually some of the staff, you have to follow them up. Then if anybody went beyond this district, you have to follow them up wherever they went. So you cannot limit it there. If we know somebody was in this family but has traveled to Kampala, then you have to follow them in Kampala. It is a big challenge. It's not something easy. And sometimes actually the people themselves hide. When they move like here, they even switch off their phones. So it becomes a bit tricky. So it's not as easy as I may portray, but all endeavor is made to follow them up.
Good. We will come back to the issues and, of course, go back in history again. Dr. Charles, you have heard what Dr. Mwebesa has said. You are a medical doctor yourself. You've worked in the health sector. But most importantly, right now, you are a people's representative. You represent your people in Parliament and the people of Uganda. Do you think that from what you are hearing from your colleagues, whether from Mubende or your MPs that you touch base with, that there is no need to panic? Is this good and satisfactory measures that are being put in place? Are you convinced about that? And what are you doing as Parliament to ensure that the work of Ministry of Health leading in this struggle is successful?
Thank you very much, Charles. I think on the side of Parliament, in relation to Ebola, we do the functions of Parliament in relation to this particular one, besides our 4 cardinal roles, would be really appropriation in case there is need for money. Secondly is oversight. But we cannot go to the battle zone as the health committee because you don't want to commit members to go there for oversight and contract Ebola. The most we can do is keep in touch frequently, which I think we are doing with the Ministry of Health, and we keep on getting periodic updates and briefing, and then sometimes the minister comes to the house to update because she's the official spokesperson of the health sector. But I totally agree that there is no cause for panic. Uganda over the years has developed capacity because every time you're exposed to an epidemic or a pandemic, you become better at managing, and the community also there's that sensitization continuously. So they seem to get to know what to do, how to report, and our administrative structure, we might take it for granted, this issue of the LC1, from top LC5 to LC1, the DSOs, the GISOs, the PISOs. But trust me, when you get unexplained deaths in the community, it's very hard for them to go and fly below the radar. And I think if we use the experiment with our brothers in West Africa, we have not gotten fatalities as compared to, I don't know what the administrative structures are, but I don't think from the first time we had Ebola, I think that was 2001, the first big case.
Yes. 2000.
2000.
Yes, the one that claimed...
no, 2000. Matthew Lukia.
Oh, it started 2000 and then...
The one of Matthew Lukia, may his soul rest in peace. We have not seen as much devastation like what happened in West Africa. I think up to 8,000 fatalities reported. So I think over the years we have developed capacity, but people are becoming more and more aware. And the principles of epidemics and pandemics are the same. The causative agents may be different, but the general principles of how you react the broader principles of how you manage them are really the same. So I still agree, and I say that there is no cause for panic. We have gotten through worse storms before. We are just coming out of COVID. We are not yet out of the woods. And the fact that people are able to identify and then report to the health workers, I think that shows that that we're becoming more and more prepared. Now, one thing we also need to understand is our geographical location as a country. We have very good ambient temperatures, a very good environment. So we really have to take the war to these pathogens. We cannot get Uganda and take it to the cold areas. They're with us. You have the jungles of DR Congo. We don't know what's there. We went and disturbed them in 2000 with Operation Safe Haven. We came out with them.
Disturbing the germs.
We're disturbing their ecosystem. Because, and this may be, but if you, Charles, and I'll say this over again, that the epicenters of the Ebola of 2000 were in Mbarara and Golo. And that is where, when we were returning from DRC Congo, that's where the two divisions went.
Our brothers and sisters fighting.
Exactly. I was a medical student then, and we were treating quinine-resistant malaria until the cardinal signs of bleeding from the different openings came up. So sometimes you just also have to look. You don't have to look far. Sometimes the answers are there. But in this particular one observation I've made is that the areas where we are picking up the cases is linear. I think we're looking at Chegegwa, we're looking Mubende, Kampala, and Wakiso. So it is still taking a linear path. We have not yet seen it get out of maybe to go to Chotera, maybe to go to Masindi, maybe to find it in Gulu.
Explain a bit, what does linear mean in terms of spread of pathogens, or spread of epidemic in medical terms?
So if the epicenter is Mubende, that means any person, the contacts we're looking for are taking that linear path. I would be more worried than if it now starts, we pick another case in Rakai, in Mukono, off that grid. It shows that people are now penetrating into the community, and that makes contact tracing
very hard.
Quite hard. Whoever we are looking for is taking that linear path, either jumping into a taxi, either walking, and that means it has not yet disseminated off very far from the epicenter, and that really complicates the interventions and the contact tracing.
Okay.
Charles, allow me to add a small thing to my senior here.
Yeah.
Yeah, we have those problems from the
Senior in what? I need you.
He's my chair.
Oh. Because I'm looking at the years of service in the medical field, and I'm wondering, how do you call Dr. Charles?
He's my chairman.
No, his position is more stressful, so it explains
Yeah.
That's good. That's a joke. Go for it, doctor.
Yeah, I really wanted to add also to what he said
Yeah.
about importing the pathogens from DRC.
Yeah.
But I also wanted to emphasize that even here in Uganda, we have our own pathogens, which are actually as dangerous. So, you know, even during this epidemic, we started looking for what? Trying to align it DRC. It was the Sudan. Then we started asking, did he ever travel to Sudan? What? Fortunately, this was a local person in the same area, has no history of traveling to Sudan.
That's the index case.
The index
Did
case.
he-
Okay, even including the people who
Did
died
he
there.
eat a monkey, a baboon?
Exactly. That's what I want. Of course, I can't say he ate a monkey. But what I'm saying is that the problem started within. So most likely, these people got into contact with monkeys, with bats, with all those animals that harbor the viruses. So, and most likely in the caves, in mining areas, that's where the problem is. Because we've really failed to associate this problem with Southern Sudan.
Oh.
It must have been within Mubende.
And just remind us, which strain is this?
Sudan.
This is the Sudan.
The Sudan.
The one we have currently is the Sudan strain.
Yes.
Okay.
And also to add, you remember in 2018 we had Marburg.
Yes.
In Queen.
Yes.
It is also a very hemorrhagic fever which kills. And the problem started from within Queen, where people would go in the caves and interact there with bats. I say I don't know what they were doing with bats, but the problem is within. We also have our own share.
Okay.
Let's not forget that we are also carrying those problems.
Very interesting.
Yes.
Very interesting. Let me come to, before I go to Dr. Byachika, first to Dr. Ombeva. In terms of control of the disease, and we are looking at, the president touched on vaccination and though not conclusively tackled, what is the capacity and what is the potential, what is the possibility that we have for vaccinating against Ebola?
Thank you so much. I think one of the things I needed to add to what the chair of the Parliamentary Committee said is we need to realize that one of the, I think I would call it fortunate thing about this particular outbreak, when you compare with the other outbreaks, is that in the family of the Ebola viruses, the strains that affect humans, there are 4, because there are 6 total strains, which you can actually call maybe clans or sons within the Ebola viruses. But of those 6, 4 affect humans. And of the 4 that affect humans, we have the Zaire strain, you have the Sudan, you have the Wundibujo, and the Thai forest strain. So there are 4. But of all of these, the Zaire one is the most dangerous one in terms of capacity to spread very fast, in terms of capacity to progress from infection to death. And so the Zaire type doesn't give you a lot of time with the patient. So the progress is very fast and it spreads very easily. The Sudan one is a bit milder. So that's why I say it's something a bit fortunate in terms of the fact that the Sudan variant has given us room to be able to rapidly control the problem. If you compare to the other old outbreaks and even the outbreaks that we had in the Congo, like what happened in last year November in Congo, and that was maybe a distance of about 500 kilometers from Mubende, where the outbreak was, but they had the Zaire strain. They did not have the Sudan strain. So that has been fortunate on our side. And because Uganda over time has built capacity to respond to something more dangerous, which is the Zaire strain, responding to the Sudan strain has been a bit within the capacity that has been built over time by the Ministry of Health and the government. So that is why we've been able to contain it within those 3 districts. And the rates of spread and even the numbers that are dying are comparatively lower than what we know of Ebola. Ebola case fatality,
it kills up to 70%?
Case fatality rate for Zaire strain is up to 90%.
Wow.
For example, if a pregnant mother gets the Zaire strain, they'll die. Almost 100% for pregnant mothers and their fetuses if it's a Zaire strain. So the Sudan strain is a bit milder, which is something to, maybe I should say, is that we are fortunate in the sense that our capacity can be able to contain that. So the ones who have died are the ones who, like Dr. Mwebesa said, they're those ones who maybe were found towards, as they neared death, they're the ones that raised the alarms. Yeah, and then led us to be able to test. So that's one. Second thing is that now, because the Zaire strain has been what causes most of the deaths, so most of the research has revolved around the Zaire strain than these other 3 strains, the Sudan, the Wundibujo, and the Thai forest. In the process, the medicines that are available, the 2 major drugs that we know that we use to treat Ebola, and the 2 main vaccines, they have been developed against the Zaire strain. So we do we do not currently have any vaccines that have been developed against the Sudan strain, or the Wundibujo strain, or the Thai forest strain. We have 2 vaccines, one by Johnson & Johnson and another by Merck, MSD, and those 2 vaccines target the Zaire strain. And those are the vaccines that we've used in the Congo and in the other in West African region. So those vaccines cannot work for Sudan strain. So we cannot use them at the moment to contain the outbreak.
How about the president? I like how he was wondering. He was saying they're all Ebolas.
Yeah.
Why can't we try?
Why can't we have one vaccine?
Why can't we try one vaccine, the one you currently have, on the people?
That's actually a good question, because there are people who've even asked, scientists who've even asked that in the Johnson & Johnson vaccine, there is a small, how do I call it, the glycoproteins. There's a small component in it that is supposed to actually cover Sudan and Thai forest and Wundibujo, included in that vaccine. Why can't we use that Johnson vaccine to try on this? And that's the question the president wondered this evening. But the most important thing to realize is this, that must be tested in a research environment. The research environment has been done on the Zaire strain. It has not been tested on the Sudan strain. You need to remember that majority of outbreaks of Ebola across the board have been Zaire. We don't often see Sudan and Thai forest and Wundibujo the way we see the Zaire. So it has never been tested in a robust environment like that, and for that reason, it has not passed the test to be used, because they must be tested before they are used. Remember, there's a lot of questions about vaccines. You're using the vaccine, have you tested it? Yes. And so there are trials now going on. Remember, the studies around vaccines go through 4 different levels of trials: phase 1, phase 2, phase 3, phase 4. Phase 1, you have a few people, maybe about 10, 20. Phase 2, you have about 100 people. Phase 3, you have about 10,000, 20,000 people. So most of the studies now are around phase 1. Now, the challenge is usually this. To test these vaccines, you actually need an outbreak. You will not test the vaccine if you don't have the problem going on. That's why we tested COVID, because we had the people with COVID. You must have an outbreak ongoing. So we rarely see outbreaks of Sudan strain. So that has been so hard to test vaccines around it. But now that we have outbreaks now happening, the vaccines are being tested. Now we have phase 1, phase 2. So we can't use those yet.
So quietly, do they call them vaccinologists, the experts who work on you people?
Vaccines, yeah. So vaccinologists and immunologists.
So quietly, you vaccinologists actually wish that there are outbreaks of these things?
No, we don't wish. What you see, like, you cannot say that you are having soldiers because you quietly hope there will be a war. No, you just get ready, because naturally in life,
there will be war.
There will be wars. There will be diseases. So you have to be ready. You can't say we can't have an army in the country because we have peace. No, you have to be ready, because bad things happen. So good people have to be ready. Yeah.
But you see, the argument of some scientists in this country, and even I think that's the president's argument, he says we have not tested the vaccine on the Sudan virus. So how do we know whether it works on it or not? So why don't we use it as a study? Because and even the vaccines they want to bring,
any harm anyway.
Doesn't cause any harm.
And that's
because the vaccines they want to bring, which are still in the study phase, phase 3, they are also on trial. So the argument is, so why don't we do it as a trial? Use this Merck vaccine or Johnson & Johnson and try, and then we shall tell the world. Either it works on the Sudan or it doesn't. In case it doesn't, it does no harm anyway. Yeah. But I also want to remind people, viewers, that when we are talking about vaccination, it is not like the COVID vaccination, that everybody will be vaccinated. The vaccination is only the people who are in immediate risk or contact.
Okay.
The frontline workers, who could be security, who could be health workers, and those contacts who were contacts to the people who got
infected.
And then contacts of contacts. We do call it ring vaccination. The first contacts, and then the contacts of contacts. Okay. And then, of course, as a priority, the frontline workers, who include health workers, who may include immigration, let's say at borders, who may include security. So those who are at immediate risk.
Whenever you are having those those groups put at for planning purposes, you need to include the media people.
And the
Because
media, of course.
they go
as
to the
it
front
turned
line.
out,
Because they cover-
COVID hammered us badly.
Yes.
Yeah.
Because we meet you people who are from the areas in which are high risk. We are meeting you all the time to get news, to sensitize people. In the end, some of us were among the first
Yeah.
people
That's true.
to get the original COVID.
That's the original one.
But you have a great essential worker.
The original,
The Wuhan
The
one.
very first one, which was very bad, yeah?
the
No,
very
no, no.
first one, which was very scary.
No, it's because then we didn't have the vaccines and what, so people were hit so
Yes.
hard and
But the first one was not the worst.
knowledge
because
was,
the second, the
knowledge
Delta
was
was
evolving
Yes.
at that time.
Actually, the first one was not the worst,
Actually, it was
but
not
it
the Delta.
was bad in terms of the scare. You know, whenever you were pronounced or they heard that you were infected, everybody would run away.
Yeah, and even the resilience
And
in the
the
society.
family would
people
get
had it
scared.
simple.
This
And
one
the
is now
stigma.
going to die.
And the
Then you
stigma.
remember how they were, you people in Ministry
And
of
the
Health,
ambulances,
ambulance,
what?
like 3 of them. Then they come and first blockade the area. They stop vehicles from that side, don't pass. Then you see it was very
Yeah.
dramatic.
Before we realize we can live with it, you know.
We are also
tell you my
learning.
experience.
Please let me come to you,
I'll
but
tell you-
just in a minute,
I'll
just
tell you my experience when an ambulance came to my home to pick me.
yes, I remember. You
And,
were 2 weeks before me.
Yes. At first I was feeling normal. Then the ambulance came. And then I got it. And then everything changed. And
You
you
got
know,
so sick because of the ambulance.
well, even the neighbors.
I mean,
were
they're
there.
scared, yeah. Honorable is
Nobody
going.
wanted to reach my home. The stigma.
The stigma was so much.
Yes, that's true. But I remember now, Dr. Gachika, in terms of planning, in terms of at a policy level, there is now, Dr. Mwebesa talked about the risk to the healthcare workers. How are you handling it? Because we are in the media, we are told so many things that the health workers are fearing. We are in the line of death. We are in the line of being infected. We don't have PPEs. We don't have this. Is that so? What is really happening? Are you not on top of that part of the situation?
Thank you, Charles. And as the Director General mentioned, I think as a sector, we are prepared to handle and also to protect our health workers. And first of all, with or without Ebola, we have in place what we call infection prevention and control measures, which must at all times be adhered to. And specifically for Ebola, or ever since COVID came, we have tried to build capacity of all our health workers in the area of infection prevention and control, and also procure the required personal protective equipment. And as I talk now, I think we actually have adequate PPEs, we have adequate sanitizers, we have the hand washing facilities and what at all our facilities. But what is important is to continue creating awareness amongst our health workers to ensure that they utilize these PPEs. Because many times when you go to facilities, like for example in Mubende, I have a colleague who was there over the weekend. He went there over the weekend, and when we were interacting, he told me that he could not believe that even as much as there were Ebola patients in that hospital, some health workers in the outpatient department were actually not using the PPEs that are being provided. So the issue of practice of using the PPEs is very, very important. And as Ministry of Health, actually in the area of PPEs, we request our health facilities to request as and when they need them. A case is during Ebola time, during COVID time, all health facilities were receiving these PPEs whenever they would request for them. When they run out, you can easily request, and national medical stores would deliver. So the emphasis is on utilization of the PPEs. We have enough stocks. We have actually adequate stocks for masks. We have the coveralls for those who are in the treatment units. We have the disinfectants in place, and also this water and soap is available that should be used even in homes and at the workplaces. So what we are now emphasizing is awareness of the dangers of not using these PPEs, the dangers of not observing the infection prevention and control measures. We are obviously not sitting back and saying, oh, these health workers know what to do. We still have our teams going from the center, because in our response plan, because first of all, we have a response plan for COVID. We have, within these last 2 weeks, we have already developed a national response plan, and we have different pillars to address the different intervention areas. So we have a case management pillar that actually focuses on infection prevention and control. And one of the activities there is still to go down to those health facilities and continue training our health workers in how to use these PPEs, because you don't take it for granted that they are health workers, they know. We have to continue with continuous training and capacity building.
Okay, good. Thanks a lot. Let me come to Honorable Mapenduzi and Councillor Sarah. Starting with Mapenduzi. The question of Dr. Charles explained how, this is still restricted to within a certain geographical location, but by the time the president was coming to allay fears and to cool down the population, there were already fears. And social media is now one of the drivers of the scare. Social media is good, but many of us are now misusing it and abusing it and using it to throw in all kinds of, excitement, fake information, disinformation, misinformation. And then before you know it, they're saying Kasangati has a patient. Then they're saying that there was one in Chotera. Then they're saying that there is one in Zombo. Those were in the course of the week, Monday, I think, or Sunday, when they were coming up. How then do we, how do we ensure that our people are helped to get the right information? How do we ensure that we avoid alarming people and as a country, and make sure that we rely on these experts to manage effectively? Is it possible in your view?
It is possible, my brother Charles, but let me not start from that very point. First, I would think that when people begin to develop fear and they begin to panic, it is not coming from the blue. It's majorly because of the experiences we have had. Talk about what happened in Gulo, but also talk about a lot of the information that we read about Ebola, a lot of the cases. And I think doctor and the team at the ministry, yes, they need to, just like they're doing, give assurance to the country, but I also think it would be important to prepare the country to know that yes, we have this that is being managed, but we can have more and anywhere. So what is important is how we are going to adequately prepare ourselves so that at any moment when we have an outbreak, we are able to manage, and people will begin to have the confidence that, look, whatever happens, it's manageable. So to me, the question is not about the fear and the panicking. The question should be, how do we build, how do we make sure from the positive efforts that have been made so far, how do we do much more so we are able to detect early, so we are able to manage, and also we are able to engage our scientists to very quickly work on the vaccines, and like Dr. Yes is talking about. You know, Charles, from the time the virus, the Ebola virus was first described, I think in 1976.
76, yes.
Yes, 1976. Around Ebola River in the Congo. From that time, there's been so many outbreaks. In Congo alone, from 1976, 1977, 1980, actually even this year, between May to July, there was an outbreak where I think they had about 5 cases and all the 5 died. So 100% death. Okay? That was this year in Congo. But I think the worst was...
You know, those brothers of ours interact a lot with monkeys on the table.
You have said it. You have said it, so...
Yeah.
Yeah.
But I will be asking another question because I am also wondering why our brothers who are on doing our roads, our brothers from China, Korea, why they are not, because they interact even more than the Congolese with these animals.
Maybe we can talk about that, but let me just say this.
Including the snakes, a lot of interaction.
Where I want to agree,
the snakes don't have Ebola.
Where I want to agree and also commend Doctor and the team at the ministry. In 2018, there was an outbreak in Congo. And I think the number was scary. About 3,000, more than 3,000 infection, but over 2,000 died. That was in 2018. But why I am commending you is how the ministry managed the borders. I think there was only one family, a boy and a few family members.
Yeah, grandmother and...
Yeah, 3 cases from one family.
Yes.
And the ministry was able to very quickly detect
and contain,
establishing the emergency response team, containing, and it never, crossed over. So the cases were, that should be how the ministry should be supported more and do the same. So the question of the current one, I wanted to ask, but you have clarified, Doctor. You said from your tracing, looks like this particular case has nothing to do with Congo. Has nothing to do with Sudan. Looks like it's local. So it takes us to the question of how do we continuously create awareness so that our people are able to, even when there are signs and symptoms, our medical people do not mistake as if it's normal fever and all that, because by the time someone dies and you detect, you will not avoid having more than 2 or 3 people dying by the time you begin to. So I think that is important. But Charles, one other thing. I will take you to what happened in Gulu.
2000?
2000, around August.
When we lost Dr.
Actually, the first confirmed case was on 30th of August in 2000. And went up to around January of 2001.
Yeah.
I like your figures.
That period was an extremely difficult period.
Yeah.
But just like Doctor put it, the medics did the tracing to find out where it came from. Actually, the village where the first victims died is not far from where I come from, where I was born. So the village of Ruarobilo. And this village is not far away from the main barracks. So the tracing found out that actually that family had a link to the people who returned from Congo. Okay. All right? Mm-hmm. And that family lost a number of people. But when you look at the period, within a short period, and that's where I want to agree with you that the Congo strain, I mean the Zaire strain, is actually highly contagious, because within a short time, about 424 cases, 425, about 425 cases, but about 224 died, about 50%, including medics, high-profile medics like the late Dr. Matthew Lokuya, and many other medical workers from Lacho, from the regional referral. But that also, in a way, has shaped the way the level of preparation, which I think the country needs to build on that. Because you remember in 2014, when there was an outbreak in West Africa, Guinea, Liberia, Sierra Leone, and all that, infection, I think, went up to about 28,000, and about 11,000 people died. So Ugandans were taken to go and help in the fight. And there are many people from Gulu, those who volunteered to fight the virus, were taken to Liberia, including the late Major General Julius Okera, who was in the front line. They were awarded medals for fighting the virus. And so I think, in terms of manpower, in terms of the knowledge, in terms of how we can manage, I think we have that, based on the experiences. But then the ministry needs to be supported, just like Dr. put it, Dr. Francis, Charles Ayume. But I also think the ministry needs to consistently keep on. We don't need to relax. Because now, maybe tomorrow, you are talking about bats. In Amoro, there are people who eat bats. Okay? And it's public knowledge. There are people who eat rats in some parts of the country. There are people who eat monkey. There are people who... So if we are getting from this, from bats and all that, what about tomorrow if we have an outbreak in Amoro? Yeah. Okay. So we should start mapping these areas, preparing and building the capacity of the community, but also the health workers in those areas. Okay. Yeah.
We will come back after Sarah. I think after the break, we need to, I'm going to task our doctors on what the difficulty really is with tackling sensitization, for two reasons. One, that actually wild animals are actually dangerous to eat.
How about bushmeat?
Isn't it true? Don't they come from wild?
but doctor said bats and monkeys, so.
Because, but for the second reason is that actually it is for the protection of the wild, the wild animals, is, avoiding trafficking and all this. But the most important one that we can use, because human beings fear, danger. Human beings naturally fear dangerous things. So why don't we tell our people that actually these animals that you like shooting, you like chasing after and poaching, carry actually the diseases that are even worse than the known diseases that attack human beings, But Sarah, I need to bring you on.
Not on bushmeat.
Not on bushmeat. But if you want to tackle bushmeat, please. But for me, I'm looking at more of the management, the capacity. It has already been talked about, and are some of these things avoidable, or it is what we must always know that we shall live with, in your view, from socialization perspective?
Yeah, thank you, Charles. I think Uganda has a track record so far of managing pandemics to a bigger extent, and I want to start by thanking our guests from the Ministry of Health over time, Uganda has got a proven track record of managing pandemics, with some challenges here and there, but I would really score them at 80%.
That's a
Which
good
is
score,
still
huh?
a distinction one.
Yeah, I mean, it's a known
And
track
you know,
record.
it's very rare to get that from Dr. Sarah.
She's a mean examiner, so
It's rare to get that.
I think she sets exams at NBC, I think. She gives 60 at most.
You are a dean examiner.
But
At
truthfully,
LBC,
if you
so-
look at the work by our medical professionals in this country, right from HIV/AIDS, even when Ebola and countries were,
Even COVID,
struggling
even
with it,
COVID,
I'm
Uganda
coming
was-
from the time of Ebola, before COVID. We reached a time of exporting human resource to help other countries manage Ebola and other pandemics. So we really have that track record. And even during COVID, challenges of governance notwithstanding, and I'll come to those, obviously.
Uganda was
So,
ranked
but
very highly
they
in
made
COVID
our
performance.
frontliners as professionals. They've really done their best during pandemics. And we wish to really encourage them to keep up the spirit, but also thank them and congratulate them where they've been successful. So far, the few weeks of Ebola, I see two challenges. One is communication. I think the Ministry of Health has relaxed on communication and let the media take over as a primary source. And that is problematic because they have limitations. You have probable cases, you have confirmed cases, you have contacts of contacts, but when you don't take the leadership on communication, nature abhors a vacuum. It's natural. Other sections will take over. And those are the contradictions we see in the media. So my call really is to the health personnel to take leadership on communicating and sensitizing people. Because information in managing pandemic is very critical. People need to know what is happening in an area, how do they prevent, are they in a safe zone, are they in a dangerous zone? I had the president categorizing, two highly.
The three.
Yes.
Very high risk.
Very high risk, high risk,
and then high risk, and then
and
others.
moderate.
moderate, yeah.
Yeah, so somebody needs to know, am I in a moderate area? Am I in a risk? So that people behave accordingly. I want to pick on an example of the people who escaped from the isolation center in Mbende, 3. Then one was traced in Masaka with all positive symptoms. But other than what we saw in media, maybe if I may talk on a personal perspective, and yet I follow up news, I haven't seen the follow-up. So what happened to the one who came to Masaka Hospital and collapsed? What is the status? Is Masaka among the districts that are in the 3 categories? Is it among others? Is it among, where does it fall? And Masaka is an entry point for many people. It is the people doing trade, business, so that information needs to come out. What happened to that case in Masaka? We saw in the news another person who entered Tanzania. And I was like, okay, so should we now export Ebola? To our neighbors. Then what happens to all the other business we are doing with Tanzania? You want to bring it to a close? So that kind of communication is important. If you leave it to the media, that's why there's a lot of speculation. When the president says there are 3 districts that are so far affected, just before the president came to talk, I watched the news and they are mentioning 4 districts, with the one I think where the prime minister comes from. It's called what? Yes.
Kakumiro.
Yes.
I think he talked
But
about
that's,
it as
I'm
well.
talking about the vacuum. No, he talked about it in the 2nd category, but the media was putting it in the 1st category. So this vacuum has so many
misinformation.
dangers and the misinformation. So the ministry needs to take leadership on that. When it comes to the issue of, I saw the health workers in Mbende that came into contact and tested positive. And we've been seeing, just from Sunday, I think, the chair of the Medical Association, Uganda Medical Association, saying if there are no PPEs, they are calling on the doctors to withhold their services. That is another dangerous vacuum that you need to cross. That is a dangerous gap. My namesake here said they have enough PPEs. Already the medical personnel are infected, and the medical association is saying withhold services until you get PPEs. So which is which? And if you have PPEs, how come the medical association doesn't know? And if you don't have it, can we then look at the chair and the MP here processing a supplementary budget? You know, that truth needs to come out. If you have it, why are the medical personnel getting infected? And if they get infected at this rate, you have 19 cases, 6 of them are health workers. Isn't that a danger to the frontliners? The ratio is high. So what happens? So to me, these are really the gaps that we must deal with facts and not propaganda.
Okay, very, very good from Sarah.
Let me make a comment.
Doctor, just hold on a
close.
bit. I need us to go for a break at this point. When we come back, we will then engage and make follow-ups on the issues that we have been discussing and go around and also take some questions. I've seen a number of questions coming from and comments coming from the viewers out there who are following. Very interesting discussions indeed, and on very important issues that affect all of us, with the exception of nobody. Let's go for a break right now, but keep it here at Behind the Headlines.
Ni MTN Kabode Super as you pay mpola for this smartphone. Make calls, update your WhatsApp status, watch YouTube, and Google anything under the sun with 2 GB worth of data every month for 7 months. Simply make a small deposit of 99k and pay the balance mpola. You can pay in daily, weekly, or even monthly installments while you enjoy your new phone. So what are you doing today? Visit any MTN shop near you and get the MTN Kabode Super easy.
The prolonged closure of schools during the COVID-19 lockdowns exposed institutional failures such as weak law enforcement, negative social practices, parenting challenges, and the general vulnerability of children, especially girls. Government of Uganda, through Ministry of Education and Sports, invites you to participate at a high-level regional dialogue under the auspices of the National Campaign to Address Defilement, Teenage Pregnancy, Child Marriage, and Promote Positive Parenting. The overall purpose of the campaign is to mobilize the country to address these challenges and to promote positive parenting. The campaign under the slogan, Protect the Girls, Save the Nation, is championed by the First Lady and Minister for Education and Sports, Vice President and Prime Minister. The 3 champions will be in attendance at the dialogue, scheduled for 29th September 2022 at 10 a.m. to 4 p.m. at Wanyange Girls School in Jinja District.
Yo! Airtel is giving you bigger data bundles for the same price. Dial star 175 hash to choose from our range of bigger Chillax bundles that don't expire and stay connected longer to loved ones. Airtel, the smartphone network.
Do you need data collection services, data analysis and reporting, monitoring and evaluation systems? Then contact Mold Technologies, a professional research firm that has provided many organizations with timely research solutions for over 15 years. For more information, visit www.mt.co.ug or call us on 0704 913 399 or 0782 602 963. Visit our office in Kampala at Sayuni Complex in Tinda. Mood Technologies, your professional research firm.
Beat the back-to-school hustle today. Pay school fees conveniently using Airtel Money. Dial star 185 hash. Select option 6, school fees.
Select to pay using Bridge Schools, School Pay or Beg Pay.
Select option 1, pay fees. Enter student number. Enter the amount. Enter the PIN number to complete payment. Airtel Money. Instant, secure, borderless.
Forget last season. Forget the oohs and the ahs. Forget every moment that stole the show. Because the real show is here on GoTV. It's the new season. It's action-packed and it's going to be non-stop football. With over 1,000 games from more than 7 leagues and cup competitions plus a World Cup. Make sure you get the best seat in the house this new football season. Get a GoCoder with 1 month of GoTV value for only 25,000 Uganda shillings and enjoy non-stop football. GoTV Uganda. Love it.
Because it is so hard to train a doctor to that level of, because they're just becoming specialists.
Welcome back from the break. This is Behind the Headlines, and we are looking at the health sector. We should not forget, we need to touch on aspects of the history of the performance of our health sector as well since independence. But we are focusing right now on the challenge that we have currently, the Ebola virus, and that has attacked Uganda, especially starting from Mubende area and the surrounding districts. Before we went for the break, Dr. Mwebesa, Sarah especially raised that gap of communication, and the challenge of communication comes in many ways. There is misinformation, but also because of the gap. Then there is the question of, and it gives room for purveying of fake news, and then information goes on its own, and before we know it, people are, excited, people are, are worried, people are so anxious because the information coming out is not the correct one, and yet it is still coming out. Information will always flow. I am told by my production team that they want me to start with some messages. They are here, they are. Makasi Edward in Kasese says, I like the presentation of Dr. Mbeva that for a trial of a vaccine to take place, there must be an outbreak. How long does this trial take, or how long do these trials take? I'm Morife from Tororo. My concern is on frontline workers, even those families that lost their loved ones who were frontline workers during COVID haven't been compensated, and this demoralizes the health I think the health sector or health workers. Okot Moses says, from Gulu City, says the healthcare experts are of high risk than the rest of the citizens. I therefore request the government to consider them by giving them better pay and make them happy amidst this outbreak. Next, Tracy J. Fred from Masaka says, it is just for us Ugandans to be very careful, but we must fear. The message was not completed. Bwambale from Kasese says, to the chairman of the health committee, that's to Dr. Charles, is there any plans to give extra attention and care to medics who have tested positive for Ebola? Charles, doctor, you will have to answer that. Nahurira Joan from Kololo says, The outbreak of Ebola.
Kololo, of all places.
Oh, is that a name?
Koboko, Kololo.
Kololo.
From Kololo. I thought that is a name. The outbreak of Ebola is nothing but the end of the world. Is that so, Joan? You are, I don't think so. Lukuba Robert in Masaka says, Masaka is not included on the president's list, yet the Ebola patient is admitted at Masaka Referral Hospital. Is that the one Sarah was talking about?
Yeah.
Simon from Tororo says, biblically, Ebolas were disease God threw to the Egyptians because of rebellion. They told you not to host nyege nyege, you insisted. So those are the repercussions of nyege nyege. That's what Simon from Toronto. Simon, you are in a world of your own.
I think he has been reading the Bible.
Simon is a doomsday.
Then it should have started in ginger.
Then it should have started in ginger if it was because of nyege nyege.
You might find ginger people didn't go.
Oh, ginger people did not go for the nyege nyege. You mean
Mubende people came from
You know, Charles, that sounds like what a gentleman told me during the outbreak of COVID.
Yes.
He came and said, you know, I was still chairman of Kulu. He said, you know, chairman, this COVID is coming from China because they destroyed our shrine when they were working on the road. And it's a punishment. I said,
no, of course we deal with a lot of such challenges, theorists and all that. So, Doctor, one or two questions that have come from the viewers there, but especially the question on managing the communication. Why do you people leave gaps for the speculators of fake information, misinformers to take the lead, and then your information comes later? That's what Sarah is asking, and the number of these questions coming up.
Thank you very much, Charles. Actually, also, Honorable Mapendus commented on it when he was talking about the social media. You know, honestly, we're not here to be on defensive.
No.
Or to try to defend ourselves.
Yeah.
I really want to agree with them that we need to be upfront, ahead of the media. What we are almost doing now is reacting. What people throw in the media, people what throw in the social media. So this is a lesson learned from this meeting. I think what we need to do as a ministry is to come out regularly and give people information so that we create what Sarah calls a vacuum. Because once there's that vacuum, then people throw in their information and everybody reading the information believes it. But if our public relations team and even us, the technical people, should come out regularly and give that information so that everybody is up to date. So that even if somebody throws in something, people will say, but we got the brief yesterday. This was not given. And then maybe when you come again the next day, you even clarify on what was flagged yesterday. So I think that's a good lesson I've learned from this one. We should go and up our game in terms of updating the country of what is happening. And we don't have all the time to wait for the president to come and talk.
Yeah.
Because for him, he comes and talks on the bigger things. But the regular updates, we should be able to do that. And I agree entirely.
And maybe, Charles, just to add, in terms of the response, that's one avenue. But I think also Parliament has taken note of sometimes the free space of like social media, and I think recently the Computer Misuse Bill, Amendment Bill was passed. But then when we're amending the Public Health Amendment Bill, there were issues to do with mandatory immunization, and that a number of stakeholders who were coming before the committee, that was their concern. So we said, no, let's maintain the traditional immunization schedule. But for emerging threats, it won't be mandatory. The onus will be on the government to avail all the necessary information, and then people will make the informed choice. Like if it's a new vaccine, it's a new disease. However, we ring-fenced it again by saying whoever is caught going to counter government's position, if you don't want to go for vaccination, do not go, stay in your house and don't go. But for you to go onto a pulpit, and for you to go onto radio and campaign government's position, because remember, by the time the Director General advises the minister, there is already a scientific committee on immunization, the UNITAG, that has looked at all the various receptacles and has advised the Ministry of Health, and the Director General has advised the minister. So there are some people who will go onto the internet, look at a paragraph in Peru or in Brazil, extract that paragraph and then circulate it on social media. And if that person is an influencer, trust me, he'll carry about 10,000 people with him. Some people will go to the church or onto a pulpit and decampaign the position of government. So some laws, like for example the Public Health Amendment Bill, we put that clause that we shall be able to have punitive measures for such people.
Yeah.
Case of Masaka.
Yes.
Dr.
That is for Dr. Mwebesa or for Dr. Viachika?
I don't know, the ministry.
Okay.
What happened to the person who was found in Masaka?
I think what we will do, the person is isolated. We are not very sure if he is positive. I think, is it he or she? Positive
We're
or
waiting
not?
for the results, I think.
And then as soon as we get the results,
then you move
then we shall
appropriately.
announce.
Okay.
And then of course that will mean some other serious consideration for massacre. And of course that may also mean where did she pass.
Yeah.
It gets a bit more complicated. Where did she pass, where she passed.
How did they
Because it's not yet a case, it's a contact of a case.
She was a contact, I think, if she's the one who came from, because we know cases escaped from massacre, from Mubende. Yeah. But we are not sure if she's one of them. But what we also know that the results of those people came and they were negative.
Yeah. Okay. Dr. Charles, there is the question of the sensitization on contact with the wildlife. How do we handle it? Is that something that Parliament should weigh on?
I think right now the approach to health is we're looking at the One Health approach, where we're not looking at health in silos like human health. We look at human health with interaction to plants, because there are some diseases you can pick up from there, but also, most importantly, animals, whether domestic or wildlife. So that is the current approach, the One Health approach, and actually when we're amending the bill, that is something that we called for. And the international health regulations also recommend a One Health approach.
Okay. Dr. Sarah, the question of control, prevention. I saw the minister, your minister, together with the president, trying to emphasize the issue of washing hands with soap and all this. And it brought me back to...
And shaking hands.
And then, of course, yes, shaking hands and all that. As a preventive measure, it brought me back to where we always start. That treatment, curing, or healing, which is your work, is usually more expensive, and that is it 67% or even more of the disease that we suffer from in this country are actually preventable. Simple things, washing hands, and how much are you again back to awareness? Are you sensitizing people on these actions with different organizations to ensure that this is done and done adequately?
Yes, thank you very much. And as you've rightly said, over 75% of the diseases, at least here in Uganda, are preventable. And they are preventable actually at individual or household level, just from the way people behave at home. So as we are also now within the sector, we are also have prioritized health prevention, health promotion, disease prevention, sanitation, healthy living, nutrition, because all those contribute to the burden of disease in this country. And we know that as health, Ministry of Health alone, we cannot address that. The other non-health sectors actually are the ones who are key in addressing these, what we call the social determinants of health. So when we talk about, for example, sanitation, as a health sector, we can promote by educating the individuals, the households, that you need to wash your hands, you need to wash your body, you need to brush, and all that. However, we are not responsible for providing the water. So that brings in the water sector that has to ensure access to clean water. We need to bring in the local governments who actually have to ensure that people have the toilets, the basic or improved latrines in their homes to reduce on the open defecation. We also need to look at early health seeking behavior, because sometimes because of cultural or education levels and other factors, people do not seek access health care in time. In example, like for example, if a family, 2-3 people died in the family, the most, the immediate thing will be, oh, somebody has bewitched, because of the culture, traditions, and beliefs. So we need to work collectively with cultural institutions, the political leaders, and all other stakeholders. But when it comes to right now, we cannot now say, oh, other sectors should do this. We have other key stakeholders, especially civil society. The civil society has been very useful and continues being useful. Also, other implementing partners, they are really supporting the sector in ensuring that we do sensitize the community through radio talk shows, but also through community dialogue. And as a sector, we already, the DG talked about the village health teams. That is also another frontline workforce that we have. And for example, during the COVID-19 pandemic, we tried to tool them. We procured megaphones for all our village health teams so that they can be able to move from home to home and educate them. We have been able to produce some IEC materials with support from our partners in terms of posters that we are distributing in the communities, in the schools and public places, and also at our health facilities. But what we really need to ensure that, like we did with the COVID-19, we need to have a multi-sectoral approach, because as health alone, we shall not be able to reach the people. We need to bring in other sectors. We need to bring in the Ministry of Communication to be able, especially the issue we have just talked about, the issue of communication, sensitization. I think we need to have more engagement of other sectors to be able to address, increase the community awareness, but also to address the other social determinants of health that would affect the outcomes.
Mm-hmm.
Yeah.
Okay, that's a good one, and I like it because we were in discussions today with some organization, WASNET, dealing with, they call it WASH, water, sanitation, and hygiene issues. And I noticed that you actually have at your disposal, as the health sector, as Ministry of Health, you have at your disposal a number of organizations that across the country and that can actually disseminate some of this information that are preventive, or many times we don't get that kind of information coming proactively, and that's where there is a gap. But coming to Dr. Malande, there was the question of at a regional level, how are we doing? And in terms of, you know, de-escalating the scare, or even to try and avoid causing damage to things like tourism and all that, economy. I saw in the, I think, was it Monday paper this week of Daily Nation, the headline was Ebola next door. And you can imagine such a scary kind of headline. How do we handle this kind of emergency or outbreaks at a regional level? Are there some ways that we can de-escalate the excitement, the misinformation?
I think one of the biggest challenges that we face at the moment, and I think what many governments and institutions face, is social media. Information moves very fast. You could imagine someone sends a WhatsApp message now to one group, and if the group has 300 people, the 300 people, let's say 30 of them share to 30 other groups. You have information spreading from here to the US and back and to South Africa, like in 5 minutes, you potentially can spread, you know, a scare around the world. And that, of course, I know it's posing a big challenge even to governments, you know, at the level of communication. That's why I really appreciate what the president did today, to just come out and provide confidence. Because while we think that it was for a Ugandan audience, but that information has spread everywhere. Because it's important we realize this in the East African region. I actually think in the East and Central Africa, I think in terms of management of outbreaks of this nature, Uganda is best equipped than all the other countries. Just before I came here, I was in another meeting, a strategic meeting for Kenya, and planning for this outbreak, and how best the country can prepare itself, you know, just in case anything happened.
That's
and if
Kenya.
you look at and if you look at the two capacities from the
so
discussion,
they're planning now,
yes,
ahead,
you know, ahead to see just in case something happens and we have a case in Busia on the other side of the border. What do we do for ourselves, and how can we be ready? Do we need to vaccinate? Do we need to begin buying PPEs to take them towards the border and have, you see, so other countries are also thinking ahead and asking themselves questions. What do we do? You just had Sarah mentioning that, I mean, if you are dealing with Masaka, then you are very close to Mutukura, and what do you do if you are Tanzania, and how do you best prepare? And that's why I really appreciate two messages that came out of what the president said today, that it's easier to actually contain Ebola than it was to contain COVID, by virtue of the fact that the way they spread is a bit different. Airborne diseases and droplet diseases spread faster than the others. I mean, measles, which is the most contagious disease ever known to man, is droplet. You know, through droplets, that's how COVID spreads. Again, Ebola doesn't spread like that, so you can actually contain Ebola. So I think the neighboring countries, what they need to do regionally, and in fact from a tourism standpoint, is one of the things we need to state clearly is that Uganda has, by and large, developed capacity to deal with this kind of conditions. One, to make sure that it won't easily spread. I think that is happening. That's why it's fairly contained in those 3 districts. But second, to say that the other countries should not use that as a reason to be asleep. They actually need to begin to put in place measures just in case. And one of the things is we can share information. We need to leverage the information we have and share with our counterparts, you know, and share that knowledge, kind of like cross-pollinate the information that is available so that other countries can buy from that.
Dr. Mwebesa, do you share this, when you are into this now kind of crisis, epidemic management, do you do a frequent sharing with your colleague like in Kenya, South Sudan, Congo? Does that happen, or they get it on their own, they plan for themselves?
Certainly, Charles. We share this information with our neighbors. This morning I had a long telephone conversation with the DG of Tanzania. He was also scared about that room of somebody who had gone there. And then we discussed and we agreed. It is a requirement, international health regulations, you have to share.
Okay.
And it is common. Actually, if I remind you, during the outbreak in the DRC, those people did a great job. And most of the cases that crossed, just contacts who crossed into Uganda, we were alerted by DRC. You know, sometimes we look at DRC and we think their systems are not strong. DRC has a very good system of surveillance. A number of cases crossed to Alwara and they alerted us. And we had to move in. Some crossed to Ntoroko, they alerted us. So we share that information. When we had Marburg in Kenya, in Kweni, some of the people, the contacts, actually went to Kenya to hide there when we were looking for them, and we alerted Kenya. One of them, some of them went to a traditional healer on the other side of Kenya, and we had to alert them. Normally we do it either directly to government or through WHO. So like information we have, our WHO country representative alerts the country representative there, or government to government. So, and in some situations we even have cross-border. They say if the epidemic is near the border, like we had with DRC, then we have cross-border meetings almost every 2 weeks.
Okay,
and there's
yes, doctor.
A WHO regional office in Congo, Brazzaville, which the country WHO officers have to report to, so it sets regional alarm bells.
Wow, that's good, very well coordinated. Sarah, moving forward, in terms of, I want us to briefly touch on, Dr. Mwebesa, someone has just sent me a message, and I need to bring this to your attention. Someone is saying that take note that that there is were you doing some tests for suspected reports from Amuro as well? Someone is saying that there was a test from some contact in Opara sub-county in Amuro, and which was documented, and surveillance was activated, and a district Ebola task force now will have to sit tomorrow at Aware Health Center. Take all precautions in the course of your work and notify your teams to be on the alert. Join the meeting of the district task force tomorrow as a matter of urgency.
You know, Charles, what is happening now, and which is good. When this problem starts, then there is a lot of fear and a high index of suspicion. Like yesterday, but one, there was a case they suspected in Arua Hospital. Arua also.
Yes, I heard about it.
Yeah, and the staff quickly isolated the patient, took off a sample, drove it to Kampala. We are waiting for results, and I think they should be out today. Then the same in Lira, which is okay, because, but you can also not rule it out, suppose it is actually positive. So when this happens, there is a very high index of suspicion, and anything that comes close to signs and symptoms of Ebola, they quickly isolate you. Take off sample, and then, so we are expecting that, and we are going to get very many, we call them alert calls or something, false alerts or something.
Yes.
There are going to be many, but it's also good, because suppose it is true.
For probable cases.
No problem. No, probable cases are actually real, but they die before we know.
Yes, Sarah. I think we are left with, I think we still have some time, about 20 minutes, but very few now. Touching on, Sarah, we had to dwell on the epidemics, but in your status of, and then I will end with Dr. Mwebesa, in terms of looking at Uganda dealing with some of these issues, we have already seen how Uganda has built capacity and all that, especially with the recent epidemics. Where would you place us compared to where we came from? Are we in a very good position? What should we do right?
I think in terms of history, the first hospital, Mengo, started in 1897. That's what I read on the entrance. And I think that marked the beginning of like Western medicine, and maybe major element for the missionaries, for the people they were converting into Christianity. I think that starts us off with the history of infrastructure in terms of hospitals in Uganda. But if you look at the data from 1956, we had about 175 health centers. And to date, I think we are above 4,000, but the Director General is here. So in terms of infrastructure, the biggest development has been at primary care level, and that creates access for communities. And I think the biggest increment of hospital infrastructure, including health center 2, 3, and 4s, are at that level of primary health care services. If you look at the secondary health care services, we have the referral hospitals, which I think are 9?
16.
16, yes. But they are, in terms of distance and population, I think there is a bit of limitation there. And in addition to that, I saw the medical team in Chegera saying their ambulance is down. So since we have the people here, I think it's important to mention, I saw it in the news, they were saying they need to have their ambulance running, given that they are on high alert for Ebola. So if you look at the transportation for referral services, most populations have challenges in terms of transportation, and that affects access to health care. But if we are to generalize and say 1897 to 1962, we shifted to Western medicine, and in the next 10 years, right from independence, we had rapid expansion of healthcare infrastructure in the country. 76 to 86, because of political instability, I think there was no expansion of healthcare infrastructure in the country. 86 to 2015, we had now bringing in the private sector players in the provision of health services, as well as the expansion to the primary levels, local health centers. Most of them expanded at that time. And 2015 to date, there is a bit of specialization, or which is regarded as tertiary care expansion. But in terms of our demographics, if you look at the rural population, the poor, the less disadvantaged, there are challenges with access to health care because of limitations. Most of government hospitals or government aided, I don't know whether there's a difference there. You find at times they've run out of medicine. You come to national medical stores, they say we have medicine. I saw Parliament was discussing why they ban medicine, yet people in the countryside don't have medicine. And you wonder whether there is rocket science in transporting medicine to these facilities. When also you look at the capacities, especially during COVID, we saw the challenges of equipment and the specialization or the tests that these hospitals would carry out. We also saw the disparities in terms of capacities on what these health centers can do. And I hope COVID helped us develop infrastructure to some extent, which should be now used in efficient management of Ebola, because COVID came in with a lot of equipment purchase and capacity building for hospitals, which I think gave us a chance to also equip our health care center. But I think we need to address issues of equity, issues of access to health care for the poor and vulnerable. They are still a big challenge to this country, and we saw during COVID, the vulnerability really was big in terms of the rich could afford being on oxygen, especially the time when the country almost ran out of oxygen. Under the second wave, the poor could not get on oxygen. The government hospitals were full. So we need to address these disparities and minimize vulnerability in terms of access to health care.
Honorable Mapenduzi, as you have seen your fair share of some of these epidemics in your own area, whether before you were already a chairman or an MP, or even now. Sarah talks about the issue of equitable, access, especially for the most vulnerable. How do you advocate for these gaps to be bridged, especially with the team from the ministry? And more especially, I think, Dr. Sarah, who is in charge of planning for infrastructure, for rollout of some of these opportunities, and even for, I think, medicines as well.
I have had a lot of interactions with the Minister of Health and a number of people in the health ministry. Yes, our country has made good progress, commendable progress in a number of areas, but there are a lot of things that have to be done. And I don't want to blame the team at the ministry for failing to do a lot of these things, because there is proof that we have a very committed team of technical people, just from what they have been doing during COVID, what they are doing now with the Ebola outbreak, what they have done in a number of instances. So in terms of the level of commitment and the people who should, I think we have a good team. Where we have a problem is with the people who take decisions at the top. There are a number of things that we can do to support the goodwill that we have already seen with the people employed in this ministry. But I don't think we are doing enough. One, in terms of providing the resources needed. Just like you put it, my brother Charles, I'll give you the example of northern Uganda. Apart from the many cases we have had, there are serious issues we are faced with. Dr. Charles Ayume will agree with me that probably it's in northern Uganda where we have the highest cases of hepatitis.
That's true.
I think it's in northern Uganda where we have almost the highest cases of sickle cell. It's in
sickle
northern.
Cell? Is it eastern?
Well, maybe
sickle cell.
comparable. Exactly. Yeah. And I'm being realistic. It's also in northern Uganda and some parts of Uganda where we have the highest prevalence of malaria.
That's true.
All right.
The central to north, yeah.
Exactly, central to north.
Chogas,
all right. And then it's in northern Uganda where we have Nordic syndrome. It's a syndrome because nobody knows the cause, and so it's not yet a disease because the name is derived from the symptomatic nature. So the nodding syndrome. So when you look at all this, then you know there is a big problem. But you're not going to blame, I would say you cannot give what you don't have. If I want you to do much, I need to give you what you need to do it. So it comes back to Honorable Dr. Charles Ayume, myself, Parliament of Uganda, and most importantly, the executive that takes decision and say, look, we want this and this and that. So we need to do a lot more. And also the other thing, DG, you see, many Ugandans are disturbed that when high-profile people are sick in this country, they have to run to Nairobi and elsewhere. When high-profile people are sick in Nairobi or in Kenya, they don't want to run this way.
For what?
No, don't ask for what. What I'm trying what I'm provoking is that we need to begin to think in that direction. So first, we can have our own people treated from here. I need to go to Badege Health Center 3 or in Oetino Health Center and get the services I need and be okay. But so that's where we need to do much more. The improvement has been good, but we can do much better, and we need to put that energy to support it. That's what it is.
One quick question for Honorable.
For Honorable?
No, Honorable, yes. For Honorable and the chair.
For the chair of the committee.
Okay, let me ask the chair of the committee. I think it would be good at during this show to update the country whether they should expect to Lubowa specialized hospital. Because that would answer the question of Nairobi.
Okay, I'll
let the chair answer that. Let the chair answer that. Don't ask.
Well, I'll ask the chair to answer that. Fine, chair, please go ahead.
Do you my time or you want to answer now?
No, you can just do it now.
Keep it for your time. But Dr. Malande, in terms of our history, the history of the health sector in Uganda, how do you rate our, the assurance of equitable access to healthcare service, and especially I like the lawyer's term, to the most vulnerable?
I think in issues of equity and equality are two different terms.
Oh, very
The way I view equity is to say that if I fell sick and I have malaria, and someone else who has higher, maybe financial or well capacity, fell sick and had malaria, that all of us should be able to recover, regardless of where I decide to go and get my treatment. If I decide that, okay, so I have malaria, I'll go to Chirudu, I should be able to receive good treatment, that if someone else who has bigger capacity or money went to Nairobi Hospital or Aga Khan, also recovers.
I think it's about
the end point,
access to the basic minimum.
Yes, the end point should be that we all recover.
Yeah.
So that if I went to Mulago and you went to India, your cancer should heal as the way my cancer will heal.
So that for you, if you are a billionaire, and for me, I'm just a basic, ordinary Ugandan, at least both of us should have an almost equitable access.
Yeah, we may not sleep in the same cozy room.
For you, you can choose to go for the highest global standard.
Much. As you go to your highest global standard, I should be recovering in Mulago.
Yes.
That's the point. That if I'm in Mulago, I should also, the end point, the sun of healing should shine to all of us.
Yeah.
Whether you are shining on the balcony or I'm sleeping on the grass. I think that is where we still have a problem. In terms of availing that equity. And remember, in the Abuja Declaration for Health, countries committed to set aside about 15% of the GDP of the countries to healthcare. Interestingly,
is it 15 or 10?
They're supposed to set aside 15.
15.
Now, the countries that have done well have reached only about 7-8% across board, even in Europe.
Which ones are those?
Even in Europe. I mean, pick the UK, for example.
Maybe in our region.
In our region here, I think
including Uganda.
I think Uganda
during COVID,
8.
Uganda is around 8.
Yeah. But that was
and
because
that
of during COVID.
Even
no, even now.
Almost 10.
Uganda is around 8.
Budgets.
Uganda averages around 8.5, which is very good for the region. Because I know Kenya is also at around 8 there, 8, 9, fluctuates around there. So not very many countries that I know of, even in Europe, have hit 10% of their GDPs. I mean, even including the UK. So the thing is that many countries have not yet allocated, and because resource constraints and things like this. So what we need to do is to try and improve, and that is what the Honorable was saying, improve capacities even for the lower facilities, the health center 2s, health center 3s, provide them with the basic minimum that is required to treat the commonest problems. Because our common problem is malaria, diarrhea, what. If we can make sure that the majority of our lower facilities are equipped to deal with conditions that affect 8-9%, 8 out of 10 of cases in the communities, then we largely have made sure that whoever goes to the health center will get treatment, and whoever goes out of the country will get treatment anyway. Okay. I think that's how we can approach the equity issue.
Thank you very much. Thank you very much. Dr. Biachika, you are the lady in charge of this planning, in charge of the money, in charge of even the policy assurance
Yes.
to ensure that we have the policy and follow it up to ensure, perhaps that's why they have lumped up those issues. The planning, the finance, and the policy. That once the policy has been made, finance in order to ensure that it is implemented right, you know.
The money follows the service.
I think it was brilliantly thought.
Yeah.
I think it was brilliantly thought to be in the hands of one person, and the person is here with us. Now, then the question becomes, why don't we implement policies like the Abuja Declaration? Okay, maybe that's too big, but that why must there be complaints of drug unavailability in far-flung parts of the country, yet we are banning, or you know, what do they call them? Incinerating drugs because they have expired from the stores. Can we do better?
Yes, thank you very much, Charles, and I would like to thank the other panelists for appreciating the achievements we've done amidst the limited resources. Yes, as a planner, we know we have policies in place, we have strategies in place, and also resource mobilization strategies. But as you know, there are other challenges that come around and which we should not really ignore. Much as Uganda is known to have among some of the best policies and strategies in the region. But when it comes to implementation, there are other challenges that may not enable us to achieve our goals. But one of them that I really also want us to start emphasizing and talking about is the rate of the population growth in the country. It is about around the highest in the region, about 3% per year. And as I talk now, when we turn it into figures, it translates to about 2 million new Ugandans, babies born every year. And when you look at the physical space, that is the finances available in the country, the allocations to the health sector are not in tandem with the population growth. So much as we may have increases in the budget, but when it translates into per capita allocation for health, you find that what we have on the table is actually not adequate to finance our policies and good strategies that we have put in place. I'll go specifically, for example, to the allocation for medicines for government alone. For the current financial year or last financial year, we had about 660 billion budget to national medical stores to procure drugs. But if you translate that allocation to every Ugandan, you find that that budget is really very, very minimal. We cannot be able to meet. And when you look at our utilization rate of for health services, we find that at least the patient or the people to health system contact is at least around 1.2 visits for just outpatient services. So that means that the budget we have constraints. We cannot meet the needs. And this has translated in what we call out-of-pocket expenditure, where people have again to pay for those extra services or commodities that are not available when they seek care. But specifically the issue of expiries. Yeah, it is true. We do have some commodities that expire, but we find that most of these expiries are donated items that we receive. And we find that as they come in, probably they do not, the consumption is actually not as would have been expected. But by and large, a lot has been done to reduce on the expiries through NMS having a procurement plan. Every local government, every district now must have a procurement plan against which NMS procures these items. But also we know the pharmacists have told us, the logistics people, that world over, in all warehouses, at least you expect 2.5% of the commodities to expire. So expiries, when they occur, they are acceptable, and we have been informed by our main warehouse, National Medical Stores, that as a country we should not really be worried at the rate of expiries. But we've also tried to put in place mechanisms to reduce on these expiries by allowing redistribution within local governments, within facilities. So in case we have a policy, in case a facility finds that they have a lot of antimalarials, like for now, I learned from the program manager for malaria that a lot of antimalarials were procured because of the malaria outbreak in West Nile region. And we find that now with the containment measures, the prevalence has gone down. So the plan is now to reduce on the procurements of antimalarials that will be going to West Nile region, and also look at redistributing what is in excess. So we have a number of challenges, but as a sector, we are trying to address those. The issue of inadequate resources is known globally, but we have to see how we can mobilize additional resources. And my chair for the health committee is here. We are really looking at how can we tap into that out-of-pocket expenditure that is that people pay because of, and have it organized or pulled together into a national health insurance scheme where we can have subsidies, or those, the poor, much as they contribute, can be able to access better quality services under a national health insurance scheme.
Thank you so much. Thanks a lot, Dr. Sarah. Honorable Dr. Yume, you had already got a number of questions to respond to. I don't want to add more as we wind up.
Thank you very much. I think there is a viewer who had talked about, was it if you get Ebola in the line of duty, or if you're infected,
that people who get Ebola in the line of duty should be compensated, something like that?
Yes.
Then Sarah asked you about the Loboa, that an update.
Okay.
And then, of course, Dr. Sarah from near you there has touched on national insurance. I mean the health insurance, rather.
Okay, I think in the, if I use the current pandemic, which is COVID, there was what we call risk allowance, which had been ring-fenced for workers who were working the line of duty. And then there was also a compensation for people who had gotten COVID, health workers, or died in the line of duty. However, Ministry of Health was tasked to pay out the first part, which was the risk allowance. Now, when we did the COVID, there was a team constituted by the Speaker last year, and I think Honorable Mapinduzi was on board the COVID task force. And when we went around the country, the money had started trickling in, but it was at a slow pace, and it was demotivating the spirit in which the health workers were executing their duties. So first and foremost, like for example now in the case of an outbreak, it has to be coming. And unfortunately, this is not money appropriate, and it is lying somewhere. I'm sure the Ministry of Health has to look within their wardrobes to get this money and suffocate another subsector under the health sector and direct that money. But for people who died in the line of duty, were told by the Ministry of Health that now that's under Ministry of Gender, Labour and Social Development. And I think it has come up on the floor of Parliament several times, tasking the Minister, why aren't they paying people who contracted COVID, health workers in the line of duty? I would just want to talk about the health sector over the last 60 years. I think it took off. Then, like Dr. Sarah had explained, there was that time of instability and all that. Now, the backbone of a health sector is a human resource. It's the only sector that you cannot replace by robotics. However advanced it is, there'll always have to be a human being behind that robot to think, what should I input into that robot? Now, if the place is unstable, you're going to get exodus. Brain drain, training schools. The sector is about mentorship. So you need senior lecturers to mentor, to train, but most importantly, mentor. So there was a period where we did not have, but not all hope was lost. I mean, even with that instability, I mean, dental school I think came into place in 1984. That was when we had the first dental school in Uganda, and I think that was also during the turbulent times. Now, the question here is, and of course, I think at the end of the 1990s, there was opening up of the private sector, because the health sector cannot run without the private sector. That's impossible. There'll be the public sector, but then there'll be the private sector to provide an alternative. There are people willing to take investment risks and basically broaden the scope of service delivery. But I must say, the health sector is like a cow. If you do not feed it, you will not get results. You will not get the milk that you expect. The doctors, let me not say doctors, but the health workers across the entire spectrum have to be paid. They have to be given an attractive payment. Otherwise, there will be that exodus. Look at critical care workers, anesthesiologists. A number are trained here. As I speak, one of my colleagues is the head of Aga Khan Hospital, head of anesthesiology. So the ones who are left here are really Pan-Africanists. They are patriotic. They have said, we are going to stand here. And for them, it's about hope. If you look at our team at Uganda Heart Institute, Dr. Manjino and team, he's so passionate. That's why I think when he came for that loan request, there was an unanimous decision across Parliament that let's give Uganda Heart Institute. Besides the fact that we need a modern heart institute, but people with the paltry figures they're earning are doing a lot of work there. And if we do not remunerate them better, there are already countries who are punching buttons trying to call them to take them. So I think that's an area we need to address. But I would also want to thank the President that after COVID, or during COVID, a number of people saw the light, that with the rudimentary applications we're using here, we're able to contain the pandemic. And there was that belief. And the center stage shifted from different areas to the health sector. So there was that belief, and I think the last financial year we're able to appropriate 394 billion for salary enhancement. And I'm yet to find out if it is trickling in, but at least we are not getting any more strikes for now. But I think that has been a plus. As we also invest in infrastructure. Now, the interesting thing also about the health sector is that about 10 pillars have to move at the same time. You cannot only invest in human resource. There's going to be infrastructure, there's going to be policy, there's going to be drugs, there's going to be equipment. There's going to be things like blood. Those are specialized services. You cannot manufacture blood. It has to be drawn from people. It expires probably every 30 days. So you have to expand your network. We have a shortfall of 150,000 units of blood. We are now building, we're going to start construction of a new heart center. It will need blood. So it really has to move in tandem. All the pillars have to run at the same time. You cannot address one for it to make sense and say the other one is going to come next year and the other one is going to come in the 5th year or at the end of Vision 2040. So the question is, how do we get the resources? And truth be told, the health committee has about 18 health workers, doctors, nurses, pharmacists, lab technicians. So we understand the challenges. Some people have been DHOs, have worked all over this country. So we understand the challenges. When Ministry of Health comes, we speak as colleagues. Now what happens at the level of appropriation is something beyond my control. But we have it in good spirit and we want the health sector to work. On the side of Lubowa, as I conclude, unfortunately, Lubowa was passed in the 10th Parliament. But if you gave me 1.4, is it supposed to be 1.4 trillion?
Yeah.
Mm.
What's the figure?
I know it is around $360 million.
Let's say one.
That's about 1.4, 1.3 billion. I mean trillion.
For a plan of healthcare, I would have put that money elsewhere. I would have put it in my regional hospitals. I would have put it in my health center force. I would have put it in general hospitals, and so forth. Because I think when you look at the investment, somebody was talking about equity. In Kampala alone, I think we have invested about 2 to 3 trillion shillings in the last 10 years. If you look at Lubowa, if you look at Mulago Hospital, the old one, the Women's Hospital, Chirudu, Kawempe, you have now, there's a lot of work on the Cancer Hill. Then you have Uganda Heart Institute, which has asked for $75 million. That's about 2 to 3 trillion in one small geographical area. In terms of equity, why wouldn't you take that further out into the country where the bulk of your population is, so that to strengthen the grassroots facilities, because the referral pathway, in my opinion, has broken down somewhere. That is why somebody is going to jump and come to Mulago with an abscess, with a swollen toe. This is supposed to be the temple of our healthcare system, where you come with secondary and tertiary complaints, not with a jigger or a blister or you've been fighting in a bar. And the periphery system should be able to accommodate that.
Thank you very much. Finally, Dr. Mwebesa, the way forward and to wrap it up all.
No, let me set my own question this time.
But I'm sure Dr. Sara is satisfied.
No, Dr. Sara is going to mark him. Even if he sets his own, Dr. Sara will mark him.
So I'll take very little time.
Yeah.
First of all, don't make me forget. I really want to thank my health workers, those in Mubende and even across the country, for the great work they are doing. Initially with COVID, but even now with Ebola. So we really thank them and appreciate them and assure them that we have enough PPE. We shall be, the guidelines are there, what PPE to use when you are in the normal clinic and what PPE to use when you are in the COVID treatment, or rather Ebola treatment unit. So I don't want to bore you with that. 2, I don't know what Sarah is doing in the politic governance area. I wish she could come in the health sector and we work together, because she really looks, she has good ideas that we could work together
be an examiner.
to improve the health sector. So can you focus your civil society towards the health sector?
Yes.
Because Honorable Mapindu's, that one is already a converted member, but I want to bring Sarah to the health sector, because she would help us a lot. Then, what I wanted to comment about is that it's unfortunate we spent all the time on the epidemics. That's why you saw our chairman was at pain explaining many other things. Actually, when we came, we had other issues to discuss. Like in the health sector, we have done a lot, what Sarah was trying to discuss. You know, when you talk about the health sector, people rush to hospitals, rush to what? But we have done a lot in preventing disease and promoting health.
Yeah.
That's why you see that we have increased, working with other sectors. The life expectancy from 48, about in early 2000, to the current 63.
When was it 48?
48, I think, was 1991.
Wow.
Currently,
1991 it was 48 years.
Yes.
Okay.
Now it is 63. That's a good achievement. We have improved most of the indices. Our children are around 180, 120 out of 1,000. The infant mortality was at 120, sometime in the early 1980s. Now it is 43. It is still high, but that's a big improvement. Under 5 was 180 out of 1,000. Now it is 64. Malaria prevalence was 42. Recently, actually, in 2011. Because of the interventions we are doing, it is now 9%, apart from the recent upsurge in some areas. So we had wanted to discuss the preventive interventions that we are taking in the country, which have improved all our indicators very, very well. And of course, the infrastructure improvement and the like. And of course, we would have also discussed the challenges. So maybe at an appropriate time, since this was for epidemics, let's have time to show what has happened since independence regarding improvement of health service in the country. And the people should not just look at hospitals. They should look at the entire spectrum of preventing disease and improving health, including NCDs, how we should control NCDs so that our people live a healthy life and our people don't get diabetes, they don't get hypertension, and how we have improved in those areas. So I think that's all I can say. But finally, I can also say that this Ebola, we are going to control it. Our 6 health workers who are sick, we are going to provide the best treatment for them, and they will be fine, God willing. Of course, we are not God, but what we can promise is we shall do the best to save their lives, and also to control this epidemic without going through 8 months, 1 year, because it has the potential of going for 1 year if you do not control it promptly. So I can reassure people that we shall try our best to control this epidemic without going very far.
Well, thanks a lot. Thank you very much, Dr. Mwevesa. And you talked about your team across the country. We really appreciate them. Yes, we can sit and talk and sit and criticize them. It's because it is the nature of our work that, they say, journalists, media people, we are supposed to always look out for where there are gaps. But we really appreciate, as a country, we appreciate. And for some of us who they saved, you know, during especially COVID, that time, we cannot take it for granted, and we are always grateful. So thank you so much, Dr. Mwevesa and your team. And thanks for coming, because we know that you were running up and down Mubende and all these other places doing surveillance, but you still found time to come and share with us updates. He
also attended the president's
address. Yes, I saw him actually. I watched him, and thanks a lot with Dr. Sarah Biachika as well, the Commissioner for Planning. Thank you very much, the Honorable Dr. Yume, for finding time. You were busy and you didn't know you would make it, but with the role that you're playing as a chairperson of the committee. Very essential, very fundamental role, and we thank you for being free and you know, candid with all the information that you wanted to share with us. Dr. Malande, thank you very much, and keep coming to teach us more, not just to teach your students at Makerere. We also need to be taught some of these things. So we thank you. To Sarah and Mapenduzi and the entire team of Behind the Headlines, this is your fort. This is your cross to carry, you know, to always ensure that people listen to you and to research on their behalf, without you know, getting. But we always thank you. we give you the pat on the back, and from the entire team of Behind the Headlines, the UBC team here, thank you. And across the country, kindly do take care. Ensure that you wash your hands with clean water and soap. Wash your hands thoroughly, and ensure that your next neighbor is safe. Ensure that you yourself is safe. Don't go home and enter the house before washing your hands and you start hugging people. In churches, in community places, please avoid shaking hands. And those of you who like bush meat, please avoid it. It can cause COVID, it can cause Ebola. Animal diseases can be very dangerous to man. So avoid it as much as possible. And otherwise, God bless you all. To those who are already sick, we wish you quick recovery. To those that we have lost, pole sana, we pray for their souls. Otherwise, bye-bye, and God bless you.
I remember the lockdown, when the streets were empty and our lives disrupted, when businesses closed and our livelihoods hung in the balance. Hospitals were full. We lost loved ones, jobs, and hope. Our children couldn't study anymore. We cannot let this happen again. We should not go back. Get fully vaccinated against COVID-19 and join the millions of Ugandans who are already vaccinated.
Millennium Garden Sazibuaya. October Munanaji Montelembara. Kuminatan October. 40 poto Muchisawe. Abidim be October. Bale Sports Center. Umtualukumo. Yebem Tualesanto. A meza million yemo. Wabula Tualukumia. Abana Gula tickets of Akosa M10 Momo. Bajagusa Sulan Comitano. Binaminam Center. Hiva Motors. Galaxy FM. Radio 4. Kagwina War. TN. Saba Furu Belamo.
UBC, inspiring Uganda.
One-on-one with Michael Jordan Lukomwao.
A weekly face-to-face conversation.